Hi, this is Brian Kim. I'm going to share with you this patient who was referred for a dislocated Crystalens, IOL, and bag and CTR complex. This is this patient's second eye. If you may recall, I posted his first eye surgery, and because he was going to lose his range of vision, he wanted his other eye set for a -2.25, which we were able to achieve. And this eye, we're going to shoot for a monovision distance target, and then I'll perform my modified Yamane technique, and you'll see me struggle to get this Crystalens CTR Deadbag complex out of the eye. So you can see this is the Crystalens. It doesn't look too bad, right? But as I use the wax cell sponge to shake the eye, you can see there's quite a bit of pseudo-phacodenesis. I use the tip of a 27 gauge cannula to ink the limbus on the right side and then the left side, using the shaft of the cannula to find 180 degrees apart. And this is a fixed caliper from Epsilon. I indent 2.5 millimeters posterior to the limbal mark and then 2 millimeters adjacent, and then I ink those indentations. I do the same thing on the left side, again indenting 2.5 millimeters posterior to the limbal mark and then 2 millimeters adjacent. And then inking those indentations with the tip of the 27 gauge cannula. This is the back of the trocar needle. I indent 3.5 millimeters posterior to the limbus, tunneling 3 millimeters with the trocar needle towards that indentation. I tunnel 3 millimeters and then I dive towards the optic nerve. That's the incision to externalize the leading haptic through a contralateral limbal incision. This is the incision for the AC maintainer, and these are my incisions to take this Crystalens CTR bag complex out. This is some intracameral epinephrine, and as I push, you can see the force of the pushing of the epinephrine is causing the lens to jiggle wildly. And I'm pulsing the epinephrine. That's why you see it jiggling so much. This is dispersive viscoelastic to fill the anterior chamber. And this is the 3 millimeter blade. I make a vertical groove, tunnel through the cornea, making sure I'm perpendicular to my limbal marks, and then I enter. So okay, I'm placing the vitrector through my pars plana incision, using it to lift the lens up because it's bowing back so much. And then I'm using microforceps to grab the CTR, actually. I'm grabbing the CTR, and then I'm switching hands, trying to go through a different incision to grab it. So that's like the CTR haptic complex. Grabbing it with my right hand, and then grabbing the CTR in a different location. And then sweeping with the forceps. I'm trying to sweep the iris around. So I'm trying to get the entire lens, bag, CTR complex into the anterior chamber. Now I do make a little mistake right here. As I'm doing this, I actually puncture through the iris, and I didn't realize that until later. What would have been better is to use the Maltzman or a Lester hook to sweep the pupil and stretch it instead of using those forceps. And I caused a little tiny puncture mark in the nasal iris tissue. Now that I've gotten most of it up into the anterior chamber, I'm trying to grab the lens, but again, it's made of silicone. It's really, really slippery. So I switch hands and I'm grabbing the lens with the IOL holder on the left side. Again, making sure I get that distal haptic finally up into the anterior chamber. So now everything's in the anterior chamber, the entire lens as well as the CTR. So I'm going to cut the proximal haptic off first because this thing is just so big and bulky. Switching to the microforceps, I grab the haptic and it pops out. So that went pretty nicely. And now I'm going to cut the optic. Again, it's thick and slippery. I'm going to cut it part ways. And again, it keeps slipping off, re-grabbing. And now it's cut, grabbing the cut piece, but I have to switch hands because I need the IOL holder to pull that piece out because it has a serrated tip. Okay, so now it's out. And then I just grab the last piece from the cut edge of the optic with the IOL holder, and the whole thing pops out. Using two forceps to grab the CTR, inching my way towards the tip, and then pulling it out of the eye. This is a 22 gauge thin-walled AC maintainer. And this is pars plana vitrectomy. So again, because when I was sweeping, I accidentally punctured the iris, you can see the pupil has lost its dilation nasally because of that maneuver. This is intracameral triamcinolone. Again, I have not encountered any vitreous throughout these maneuvers. This is a 25 gauge needle with BSS on a syringe. I'm going to bend the needle such that it will be facing to the right when I hold it. This is the right side 30 gauge thin wall needle. I'm going to bend it 9 millimeters from the tip with the bevel facing towards the main incision. And this is the left side needle, bending it at the hub with the bevel facing towards the contralateral limbal incision. This is the emerald cartridge, injecting cohesive viscoelastic through the barrel and on the platform, placing the Sensor AR40 lens, again set for about a -0.5 to a -0.75. Make sure it's pushed down, seated within the wings. Bend the wings together, the optic bends backwards, the leading haptic goes through straight through the barrel, and the trailing haptic comes out through the back. Sliding the cartridge into the injector, making sure the trailing haptic is up outside of the barrel, and advance the plunger, and I'm ready to go. And this is a 25 gauge needle going through the contralateral limbal incision. The injector is going through the main incision. I turn the bevels so they face each other. My assistant is advancing the lens. The leading haptic comes out. I dock the haptic on the bevel of the needle. As she advances the lens, more and more of that haptic goes into the needle. I withdraw the needle and the haptic's out. I deliver the optic. It comes out straight, and then the trailing haptic comes out facing towards the right. Turn off infusion, pushing more dispersive viscoelastic to push the optic back, checking my mark, and it is 2.5 millimeters posterior to the limbus. I'm going to work on the right side needle, but you can see the antechamber maintainer is in the way. So we're going to take the steri strip off, and we're going to move the AC maintainer out of the way. My assistant is holding the AC maintainer. I'm holding the trocar cannula, stabbing the first mark with the needle through the conjunctiva and sclera first, and then flattening out, turning on infusion, tunneling 2 millimeters towards the second mark, feeling the resistance of the needle piercing through the scleral tissue, and then I dive down. Using microforceps to pull the lens out a little bit more and pushing the optic away from me, grabbing the trailing haptic, sliding it towards the left so it goes in the eye atraumatically, docking the haptic on the bevel of the needle, 2 pushes, and now I'm in. Disengaging the needle from the syringe, internalizing the leading haptic with microforceps and laying it into the angle, grasping the contralateral limbal incision, again measuring and confirming 2.5 millimeters posterior to the limbus. The left side needle I'm stabbing at the first mark, turning on infusion, tunneling 2 millimeters. But as I'm tunneling, you see the eye is rotating. I don't really have a firm grasp. And of course, that's because my forceps is not in alignment with the needle. But I don't want to grab in that area. I'm still holding it at the limbus, again at that contralateral incision. And since I don't feel comfortable and the eye is turning, I start over again. And I just repeat. And once I feel comfortable, I tunnel 2 millimeters and I dive down. So I felt much better about that last attempt. Again, I'm turning the needle to face the haptic and not the other way around. Turn on infusion. I dock the haptic on the bevel of the needle. Two pushes, and then I'm in. Pulling both needles out a little bit, withdrawing the left side needle all the way, limiting how much haptic comes out. Turn off infusion, cauterize the tip. You can see the haptic is sitting nice and flat to the scleral surface. Pull the right side needle out, pulling it away from me, limiting how much haptic comes out of the eye. Turn off infusion, cauterize the tip. Both haptics are flush to the sclera, which means this lens will most simulate an in-the-bag IOL placement. Holding the AC maintainer with my right hand so I can see the haptic on the left side a little bit easier. Pushing the haptic, again, flush to the sclera, embedding the bulb. And this is a well-centered lens. Again, with the exception of me pushing on the iris tissue nasally when I was trying to pull the lens bag complex, CTR complex up into the anterior chamber, everything else looks perfectly executed. Closing with a 10-0 nylon suture through the main incision. Performing some more pars plana vitrectomy. Again, not encountered any vitreous throughout the entire case. Performing limbal vitrectomy, but again, there's no vitreous. This is primarily to remove all the viscoelastic in the anterior chamber. This is the temporal surgical PI. Again, you want the PI visible as if you're doing a laser PI. You don't want to put that PI all the way into the angle. You'll eat the ciliary body. So you want to do it in such a way that you can actually see it. And I got a nice, small, discrete PI. I'm flushing the eye with PSS to get any remaining viscoelastic out of the eye, and this will be the end of the case. So again, this is the second eye of the patient with the Crystalens, dislocated Crystalens. You saw so much pseudophacodenesis. This patient has wildly fluctuating vision, was very unhappy with his vision, had his first eye done, targeted a -2.5. He's very happy with the result. And this eye, we're targeting plano. I just did his surgery, so we'll see what his refractive result ends up. And he's traveling from out of state. And so we did everything all at once. And so he'll have to come back for his post-op visit. Again, very difficult taking this crystal lens out. You saw I had to cut it into so many pieces. The silicone material is so slippery. To pull that whole lens into the anterior chamber was really difficult. On top of that, there was a CTR. Back in the day when a lot of surgeons were using Crystalens, I remember some surgeons would use CTRs routinely. But again, in this case, I don't know if there was an underlying zonulopathy or if the surgeon just put a CTR in as part of their protocol for Crystalens. Nonetheless, it makes it a little bit more challenging to take out. And you saw I had to cut it into small pieces, multiple pieces, and then take the CTR out. Again, this was a dead bag. You saw no lens material in the bag. It was pristine. You couldn't see anything. It was really, really clear. There was no remaining lens material at all. But once I got the thing out, it's pretty easy. I put my 22 gauge thin-walled AC maintainer in. I performed some pars plana vitrectomy. I did my modified Yamane technique, externalizing the leading haptic through a contralateral limbal incision using a 25 gauge passive needle docking technique, and then using the 30 gauge thin-walled needles for the right side, using my marks to give me precise measurements, tunneling and making sure I feel the resistance of the needle to the sclera, docking the haptic on the bevel needle, and you saw how easily I was able to cannulate the trailing haptic into the right side needle and then doing the same thing on the left side. But because I'm working away from me, it's so much easier to visualize and to execute the leading haptic side, and I'm able to turn the left side needle to face the haptic. 2 pushes and I was in. These 30 gauge thin wall needles grip the PMMA haptic of the sensor so well, I never worry about losing it. I never have had lost it yet. And then pulled each haptic out, cauterized the tip, and you saw how flat the haptics were, nice and flush to the sclera, which means this is going to most likely reproduce an in-the-bag IOL placement. I feel like I've executed this surgery as well as I can in this difficult case, and hopefully when he comes back for his post-op check, he'll be very happy with his result. So I hope this was helpful to you, and I thank you for your attention.